It's all maybe because I grew up in a medical household. My father was a doctor. Um, I've always been interested in what we now call biopsychosocial medicine. So the interface between psychology, social issues, and health. And I just sort of stumbled into primary care, honestly. Um, my husband was a med peds resident, and he was rotating with family medicine residents back in, I think, 81. And they hadn't had an organized faculty member nor a woman on their faculty yet. And the residents were agitating for this and encouraged my husband to have me apply. I was just out of fellowship in Texas. And so I did. And, for a variety of reasons, I got hired. And I realized this is really the place that biopsychosocial medicine hits the ground. It's really important in primary care to prevention and early intervention and to everything that happens across the lifespan. Also, I think being family trained and interested in the role of the people's natural support system in supporting their health and their health care, family medicine also has that interest. Well, to actually implement value-based care, we've been talking about it for way too long, and it's very hard to really focus on people's health and prevention and early intervention and integration of behavioral health into teams in a kind of fee-for-service widget-based system. So we have to do constant workarounds and stand on our head and be underpaid. So I think appropriate payment for primary care that includes valuing all the behavioral components that primary care clinicians themselves provide for patients and behavioral health people on the team. So we just don't have the policy and the financial system to support many aspects of primary care, including this one. But if behavior determines, at least 50%, if not more, of patient outcomes, it only makes sense that you spend some time on that and that it's valued by the budget and by the policies, and that you can develop in training a mental model that matches the reality of patients' lives. I think as healthcare professionals, we lose sight of the central importance of tending to communication and how it happens. I run a physician communication coaching program for the Med Center, which in a sense is a way to promote primary care values across the medical system without calling them that, because then they'll dismiss it as not relevant to them in specialty care. But in primary care and specialty care and mental health, one of our primary tools and essential tool is the way we communicate with people. And I think we teach physicians to use a particular language to understand each other about especially illness and disease. And we need to also help them retain the communication skills that are important for people to get the point, for people to understand, and for us to be able to be, as much as we need to be good speakers, we need to be good listeners, and really develop the complex skills of really listening. But it's so centrally important. And I think effective communication in which patients understand and agree with and can actually implement our treatment plans is a complicated issue that is deserving of more focus than it gets. I'm proud of our communication coaching program at the University of Rochester, and it starts with coaching all the clinical chairs so that they understand and know and implement And it's a great vehicle for leadership development. Integrated care, I mean, we just stumbled on it because we developed a curriculum for behavioral health to teach residents with my colleague, family physician Tom Campbell. We developed a curriculum that practically applies psychological and family systems principles to everyday primary care. We got pretty good at that, and we're confident, and taught them how to make a referral that a patient would be more likely to be motivated to take. And then I was shocked that my colleagues in the community weren't communicating back about the patients. So I spent a year taking them lunch and saying, we just need, a paragraph after you've seen them once, and if anything happens, call, and some summary at the end. And I thought it was quite a good dog and pony show, but after a year I had to realize didn't work at all. So one day Tom just said, well, what if we hired somebody to do it here? And there weren't any regulations there wasn't any. There was consult liaison psychiatry or psychology, but not somebody embedded in how to do that. So what was great is, by 1985, we brought somebody in. It was like a dream come true. All of our problems were solved. Patients loved it. Clinicians loved it. Staff loved it. It was exciting work to do. And after a year, we hired a bunch more people, and I brought my practice in. And for 15 years, it really wasn't regulated. And so we were able to bill out of primary care directly. We were able to train all the flavors of mental health people on primary care, which is another thing that's missing. I think all mental health professionals should learn about and have to do some time in primary care so they understand how most of the mental health problems are being handled here. And we can be consultants and see patients ourselves, but most of it we need to support and train up our colleagues to do. So I think integrated care is now, really common. Fortunately, we still got a long way to go to have it really be disseminated as widely in every primary care office. We just came out with a book, Nancy Ruddy and I, called A Systemic Approach to Integrating Behavioral Health Care, that talks about all the different things you really need to think about with integration. It's not just simply hiring somebody that might end up liking primary care. That's just one part of it. You have to think about the financing, the regulations, the leadership support, the culture of the place, how biased psychosocial the clinicians are, and on and on. So it's a complicated switch from traditional medicine to actually integrating care. But it is, as individuals, we don't divide up our mental and our physical health in such a rigid way. We want to be seen as whole people, and we have to create systems that see people as whole people.